Good afternoon, everyone. I'm Dr. John Shrigley, Pathology Lead at the Canadian Partnership Against Cancer and Chief of Lab Medicine Genetics Program at Trillium Health Partners. Also the Canadian Partnership Against Cancer, Cancer Care Ontario, and Canadian Association of Pathologists. I would like to welcome everybody to today's CAP Cancer Protocol Education Session on TNM 8. Before we introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. First, the session is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. Both live and recorded presentation are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please, the CME certificates for each education session will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline. Note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and will not be able to troubleshoot WebEx issues as part of this call. If you're experiencing technical difficulties, please call the WebEx support line. To submit questions at any time during the presentation using the chat feature within WebEx. Chat instructions can be also found within the session notice. During the question and answer portion of this presentation, a session moderator will pose the submitted questions on your behalf for as long as time permits and in the order in which they appear. In the window, please include the following information: your institution, the person posing the question, and finally your question. It's my great pleasure to introduce Dr. James Brierley. Dr. Brierley is a professor of radiation oncology at the University of Toronto, Princess Margaret Hospital. He obtained his medical degree from Westminster Medical School, University of London. He did postgraduate training in internal medicine before transferring to clinical oncology. After obtaining his FRCR in the UK, he went to Princess Margaret Hospital, Toronto for a year of fellowship and stayed. He did cancer staging and cancer surveillance, as well as the management of gastrointestinal malignancy and thyroid cancer. He has written extensively on cancer staging and is actively involved in ensuring that staging information is collected and used at the population level. He was a CCO collaborative stage lead and is the Canadian Partnership Against Cancer surveillance lead and coach of the Cancer Stage Working Group. He's also co-chair of the UICC TNM Prognostic Factor Core Group and chair of the AJCC Education and Promotions Working Group. It is a real pleasure to introduce Dr. Brierley to give today's talk. Jim?
Very much, John. Hopefully you can see the title slide, and I put so many logos on the bottom, but you heard from John already that I have far too many hats. I'm going to be focusing on the changes between the 7th and 8th edition of TNM. I believe you've had a talk before from Dr. Gress, who may go into more details than I am, but in addition to this presentation, there's also the middle part, which is the differences between the 7th and 8th, is available on the UICC website for download. So I'm going to be talking about the changes in staging. The last time I spoke to this group, I spent some time talking about collaborative stage and the benefits of collaborative stage, but collaborative stage is no more, so I'll talk a little bit about that. I said that the changes between the 7th and 8th edition is a sort of a broad outline rather than any details, and a bit about what comes after the 8th edition and the future of staging. Basic, but though you need 3 essential factors for the effective management of any cancer: the site origin of the cancer, the breast, prostate, and really this is classified with ICD-03. The Blue Book is leading the way in classifying other important prognostic factors for the histological and biological characteristics, and also important, obviously, things like the degree of differentiation and just realized this is an old slide and it still has Gleason 8 there, so I apologize for that. I should have realized that. But the concept is the same, really. And finally, the anatomical extent of disease or its stage is classified using TNM. As indicated in that slide, there are other prognostic factors that are obviously very important in determining patient's outcome and also treatment. Anatomical extent of disease is just one of them. UICC classifies them as tumor-related, which includes anatomical extent of disease, but also tumor profile and biomarkers. The related criteria, age, gender, ethnicity, etc. So environmental related things such as access to care, quality of imaging, quality of pathology, and so economic status. And I'm going to a little bit about that and how you can combine or incorporate with anatomical extent of disease to the end of the presentation. So as I said, last time I spoke a bit about collaborative stage, which was introduced in the US in 2002 and was adopted in Canada. The advantage of collaborative stage, although it was the wrong terminology really, but it was a way of cancer registries being able to collect raw data. So collected, for instance, if thyroid cancer was T1 or it was 1.2 centimeters. So you collected the raw data, which made it possible to compare and analyze data over time. But it allowed for the collection of other site-specific factors, which were important prognostic factors, such as CE, HER2 new status, etc. In Canada, we used collaborative stage, and it worked really well with all the efforts that John and others had done in develop electronic synoptic pathology, which would enable linkage to the cancer registry and direct collection of synoptic pathology data with the hope of collecting in the future other synoptic data such as clinical notes, particularly operative reports, and imaging. Allowed for the collection of the raw data and with the hope to reduce the error rates and reduce the workload in the cancer registries. So it was thought to be a good thing. It also allowed you to collect T and N categories for clinical and pathological, and if there was missing data, to combine them. Finally, it was very unwieldy and very expensive, and so decided to drop it for the 8th edition. In fact, because the conversion to the 8th edition was going to be too expensive. And in the US, they decided to stop support it in 2015. This was actually a problem in Canada because of the amount of effort and resources we put into collaborative stage and collecting synoptic pathology reports in particular. It all seemed a bit strange in that, you know, the 8th edition wasn't due to take effect until for another year, so there'd be a year before the 8th edition. But the decision was made in the US to stop supporting it and for registries to collect the T, N, and M categories only and not the raw data. The CC, who control a lot of state registries, and the NCI, the SEER registries, decided to develop electronic tools to enable collect TNM. whilst that was being in the US and Canada, we would continue to use collaborative stage for another year. And in fact, we also did a survey to see what users of stage data in the surveillance and world wanted, and they still wanted the raw data. So the survey, it's a small survey, there are not that many people who use the data, but again, it confirmed that not just TNM was wanted, but the raw data was as well. It's uncertain how we're going to collect that, but as I said, the CDC and NCI, particularly the NCI, are developing tools that we hope we'll be able to use and adapt in Canada. With the 7th edition, the AJCC had planned to publish in October 2016, which they did, and start using the 8th edition in January 2017. UC was published the 8th edition in December, same recommendation to start using in January 2017. However, in November of last year, the NCI and the CDC, along with other organizations, particularly NCDB and NCCN, pushed the AJCC because there was problems with, particularly with the histology codes in the AJCC book. And the AJCC book is used as a sort of a Bible for the cancer registrars. And if there are problems with that, then they can't collect the data. And because of that, and the work needed to do to correct that, AJCC made the decision to not implement the edition until January the 1st, 2018. So delayed the implementation for a year. Has some other advantages as well, which I'll come on to. But AJC stated that clinicians will still continue to use the latest information for patient care, including the scientific content of the 8th edition. But all diagnosed cases up to the 2017 should be staged with the 7th edition. This causes some conflict because we know, particularly for some tumor types, which I'll get onto, the 8th edition is superior to the 7th edition. So it questions why you would use something that's out of date when there's a new system in process. But certainly for the cancer registries, they will be calling the 7th edition. But I think physicians, depending on their abilities, may use the 8th edition. But it's very important that if you're using the 8th edition or using the 7th edition, you state which edition you use. But let's give time for vendors to update. Gives more time for College of American Pathologists to update their protocols in keeping with the 7th edition. Otherwise, there was a time lag, and that's something we can discuss at the end with John, what the timelines are for CAP protocol. UCC was a bit stuck at this stage because we published the 8th edition and said, as with the AJCC originally said, that it would take effect in January 2017. But come on to, we know globally that it takes a lot longer for people to adapt to new editions. So I don't think this is a problem on the global front. And certainly, I think it's not inappropriate for people to use the up-to-date information when it's available. Just the background about how the 8th edition came about, the UICC and AJCC have tried to publish identical staging systems since the 5th, I think, certainly since '84. But there are conflicting needs, which I'll come on to a bit later. The CDC developed large task forces, 18 different task forces, with some Canadian representation, but not much. The task force had at least one UICC representative. Some task forces had a lot of international cooperation, some less so. Some had large databases to fall back on. Some were just American and some were international. The best example is probably lung with the international. I'm not very good with abbreviations and get my letters all the wrong way around. But the International Association for the Study of Lung Cancer, a very, very large international database. Similar in esophagus, melanoma incorporated Australian data and other data. NEC the UICC had a task force that worked closely with the AJCC task force as well. The ICC had representation on the task forces. The SEC also performs an annual literature watch, so a review of the literature criticizing TNM. The results of that are reviewed by an expert panel and shared with the AJCC to hopefully improve TNM and lead to changes. So we come to what has changed. A lot of what has changed in head and neck, but then I think a lot more changes in the 8th edition than there were between 6th and 7th edition. There are new classifications in oropharyngeal carcinoma with P16 positive tumors, new classification for unknown primaries of the head and neck, cancers of the head and neck, neuroendocrine tumors, osteosarcomas of the pelvis and spine, and soft tissue sarcomas of the head and neck, retroperitoneum, thoracic and abdominal viscera. Classifications in a lot of sites, a lot of neck, nasopharynx, thyroid, esophagus, stomach, anal cancer, liver, lung, prostate, ovary, and minor modifications in practically everything else. One of the things that was changed was in the definition of isolated tumor cells. There had been confusion in the past because in breast group previous editions had said isolated tumor cells could contain up to 200 cells, and that was by some to be true for all tumors. But so that's been defined a little bit more tightly as being less than 2 millimeters or less than 20 cells. The option is malignant melanoma and Merkel cell carcinoma, where isolated tumor cells and lymph nodes are deemed to be node positive, but all other tumors they're still deemed to be node negative. The major changes in head and neck, in all sites, there's a division of lymph node involvement into clinical lymph node involvement, clinical classification, and a pathological classification. Changes with the new oropharynx, the P16, and nasopharynx. When it comes to cervical lymph nodes, it's known that extranodal extension is an important factor, particularly in the pathological lymph node involvement. So it's mainly unchanged, except it's specified that there's no extranodal extension from N3B, where metastasis in a single or multiple lymph nodes with clinical extranodal extension is really defined as a fixed lymph node. The classification classification has changed in that N2A includes full less than 3 centimeter lymph nodes with extranodal extension. And 3B is extended to include tumors, lymph nodes more than 3 centimeters with extranodal extension, either ipsilateral, contralateral, or bilateral. So extranodal extension is now an important factor in the pathological assessment of lymph nodes at all sites of head and neck cancer. This is a busy slide, but it's from my colleague Brian O'Sullivan. What it shows in the graph on the right is for HPV negative oropharyngeal cancer, the 7th edition staging system is very good in separating survival by stage. So stage 4s typically, stage 1s do well. Use the same system for oropharynx cancer that is P16 positive, then the staging system falls apart and is not appropriate. So developed a staging system specifically for oropharyngeal P16 positive tumors, as they do so much better than squamous cell P16 negative. The separate clinical nodal category, again, the nodal category is simpler, doesn't include extranodal extension. I don't think in Canada any of these patients will have neck dissections, but there are a couple of centers in the US where they do as a separate pathological aging system, and C is purely based on number of nodes positive. Size is not important at all. This disease behaving very differently from other squamous cell carcinomas of the head and neck. And grouping is somewhat is different as well, as would be expected. Another big difference is in nasopharynx cancer, where there has been a significant improvement in outcome with both better imaging and improvements in radiation technique with IMRT. And this means that the local control rate that was 60% has risen now to 90%. And because that tumors that were classified as T4 are now curable, and in fact are dropped down to T2. Again, there's more of a clinical staging system than pathological, but it's a major change reflecting a difference in outcome with treatment. I won't go into any detail, but again, the nodal definition has changed as well, so that N3 is nodes below the cricoid or bigger than 6 centimeters. So this is important in nasopharynx nodes. And the grouping has changed somewhat as well. A difference in head and neck cancer is that there's a separate classification now for patients with unknown primary who present with nodal disease. Often rule of thumb, certainly here, was to stage as if it was an oropharyngeal cancer. Now we've clarified that it depends on the pathology. It's an EBV positive tumor in the node, then you can start using the nasopharynx classification. If it's P16 positive, then you use the P16 positive oropharynx classification. If both are negative, then stage it simply along the same lines as you would stage a P16 negative oropharynx. So if it's N1, it's stage 3, N2 is for A, N3 for B, metastasis as well as nodes for C. So there's aging system for unknown primary. The change in head and neck is significant in thyroid cancer. Differentiated thyroid cancer is one of few cancers where many years there has been a diagnostic factor included in staging, and that is age. And the cutoff has been 45, but I think many of us who treat patients with differentiated thyroid cancer know that the 45 is too low. And this data, which is really quite old now, and our own data and other data shows it's really not until the mid-50s or 60s that the process changes significantly in thyroid cancer. One change. The other change is that 3 in the past included tumors more than 4 centimeters and also those with minimal extrathyroid extension. Data to say that minimal extrathyroid extension is not a prognostic factor. This is a quote from Oscar Mete and the group here, that as the thyroid capsule is incomplete and as it and the gland contains various proportions of muscle, fibrous, and adipose tissue, the criteria for defining minimal extrathyroid extension is subjective and problematic. In addition, the data shows that in fact the recurrence rate for this minimal extrathyroid extension is 5%, which is really no different from other good prognostic thyroid cancer. It's really not until you have gross extrathyroid extension that the prognosis and the risk of recurrence rises significantly. Definition for T3 thyroid, differentiated thyroid cancer is so T3A is tumors more than 4 centimeters. TB is tumors of any size with gross extrathyroid extension invading only the strap muscles. T4A is the more extensive extrathyroid extension. This cutoff has changed for the stage grouping. Change in anaplastic thyroid, just so that you can identify the T category using the previous definitions for differentiated thyroid cancer. So you can actually identify patients with small anaplastic thyroid cancers, because in the past we know those are really the only ones who have a chance of cure. When we get to the GI tract, some things have changed and some things have remained the same. The definition of esophagus and gastric carcinoma and where the gastroesophageal junction is has changed, so that esophagus includes gastroesophageal junction tumors whose epicenter is within the proximal 2 centimeters of the cardia. So it's type 1 and 2, and that stage is esophagus. So type 3 stage is gastric cancer. So those whose epicenter is more than 2 centimeters distal from the esophagogastric junction will be staged using the stomach protocol. In this, there was a large database collected by WC, the World Esophagus, I can't remember what the C stands for, but I think it's consortium, analyzed survival. They changed the definition of T N or M categories, but there was a change in the stage group for both adenocarcinoma and cell carcinoma. So this is squamous cell carcinoma, and they also publish in both the UICC and the HACC prognostic grouping as well as just pure anatomic center disease, includes grade and location. For adenocarcinoma, there's also a prognostic grouping that includes grade but not position. ACC also publish a stage group, which is novel, and myself sure of the value, because I think the response you get does depend on what preoperative treatment you give, and the response to preoperative chemotherapy may be different from preoperative chemoradiation, and the response may differ depending on the type of chemotherapy used. So it's an interesting concept, and certainly it's worth testing and assessing. I think it's globally given the different treatment philosophies there are in esophageal cancer across the world. Cancer, again, there's been changes in stage grouping, both with a clinical stage now that's different from the pathological stage, although we know very few gastric cancers, metastatic disease, are not pathologically staged. Colorectal cancer, we work closely with the UK pathology group in trying to get wording of a deposit and get that clarified, so there were agreements. It didn't meet completely all their requirements, but we did get a consensus, and there's a consensus statement on definition of a tumor deposit. I don't think really differ significantly in what is called a tumor deposit in Canada. I don't think it makes any significant change, but it does mean to say that the UK colorectal pathologists will now use the 8th edition instead of staying with the 5th edition, which they had been up to now. The other in colon and rectum was a division in the M category. So the M category now contains M1C with metastasis to the perineum, as well as M1A single organ, and M1B multiple organ. Appendix, there's introduction of TIS, low-grade embassy, appendiceal mucinous neoplasm to the appendix. Some changes to the N and M categories as well. In cancer, there's a change in the definition of N1 to try and identify different groups of nodes, and in the past, external iliac lymph nodes were classified as metastatic, which is probably not appropriate. So they're now classified as N1B. Changes in the T categories for liver, consequently stage grouping as well. Is in definition for intrahepatic bile ducts, gallbladder, and distal extrahepatic bile duct, but not perihilar bile ducts. Some changes in ampulla and vata. And in the 7th edition, one change in neuroendocrine tumors of the pancreas was staged the same as adenocarcinoma of the pancreas, but this has been changed now so that pancreatic neuroendocrine carcinomas are staged along the same lines as other gastrointestinal neuroendocrine tumors. By itself, there was a change with T1 by size and removing extra pancreatic extension into the peripancreatic tissues or fats. I'm not going to go into the major changes in the categories based on the work in the database of the IALSC, and that was published towards the end of last year. Changes in the M category as well, so that MA is a separate nodule in the contralateral lobe, MB extrathoracic metastasis, MC multiple extrathoracic metastasis. Other ones are changes in lung stage grouping as well. Remember, there was minor change. There was the introduction of a new staging system for thymus based on a surprisingly large database that the ILSC was able to collect on thymic cancers. When it comes to sarcoma, that is in bone, in that there were new classifications and T categories introduced for spine and pelvic bone, based on classifications that the orthopedic surgeons have been using for some time, but no stage grouping. Soft tissue sarcoma changed. It was realized that I think the T1 and T2 were separated by less than 5 centimeters or more than 5 centimeters. The no cutoff is added of 10 to 15 centimeters and more than 15 centimeters. Classification has extended into use for the retroperitoneum. There's also classifications for head and neck. Obviously, the size criteria are different. A 15 centimeter sarcoma of the head and neck is very different from a 15 centimeter sarcoma of the leg. So it's not the same system. At the beginning, I said that there was a new head and neck skin classification. It was the AJCC decided to drop skin as a tumor site, but the HEC group were concerned about that as a significantly increasing number of patients presenting with advanced skin head and neck cancer. So working group was put together with the head and neck group and UICC to develop a staging system that's similar to what was used in the 6th edition. There's a cutoff of less than 2 centimeters, 2 to 4 centimeters, and bigger than 4 centimeters. It had been 5 centimeters. That's a change. The lymph criteria is similar to head and neck, but obviously for skin cancers outside the head and neck, contralateral lymph nodes are metastatic and not regional, unlike the head and neck cancer where they're considered to be regional. Grouping is appropriate. There's a change in the T1A is now less to 8 millimeters with ulceration. T1B is bigger than 8 millimeters, less than 1 to 1 millimeter with ulceration, or anything up to 1 millimeter with ulceration. And the TNM category as well, and the changes to Merkel cell carcinoma. State Gleason score has been changed to show grade instead. There's always been somewhat of a conflict between UICC and AJCC. They'll get to a bit later on what to include prognostic factors in staging classification or not. The AJCC changed the classification so that small tumors with high Gleason score, high PSA, have a high stage group. UICC, because it tries to be global and all the data is not always necessary, decided not to do that. So there is a change there. There are changes in penis and kidney and testes as well. Your bladder and urethra and adrenal cortex. Gynecological malignancy hasn't really changed, with the exception of ovary. FIGO published its ovarian classification in 2014, and this has been adopted now by the UICC and the AJCC. I'm going to go into that. Lymphoma, Ann Arbor has been simplified following a conference in Lugano, so that intermediate stage and advanced stage, so stage 1, 2, and bulk stage 2 are limited, advanced stage 3 and 4. Some subtle changes in eye. The things that UICC is keen to do is to ensure that patients can be staged and staging data can be collected in patients anywhere in the world. And certain areas, particularly low and middle income countries, there's insufficient stage data for use in cancer registries. So developed in collaboration with the NCI and initial TNM that can be used in sub-Saharan Africa and elsewhere, where essentially you start it's reverse TNM. Instead of looking at the T category, you start off with the M category. So are there metastases? If there are, then you stop staging. If there are no metastases, then you record the N category, and if there are no nodes, then the T category. Cancers, there's a variety of different staging systems used, and some of it depends on the treatment philosophy, but this isn't helpful for cancer registry community. So a consensus meeting was held to develop a simplified staging classification for pediatric tumors that can be used in the registry community. So that a quick outline of the changes between the 7th and 8th tonight. As you can see, there are a lot of changes, more changes than in previous editions, and I'm not going and haven't therefore gone into them in any great detail. Just want to spend the last few minutes talking about where we're going with cancer stage. In addition to the UICC staging committee, I am the chair of the AJCC Education and Promotions Committee. So those are two of my hats that I wear. And as I said, there's always this conflict between AJCC, whose main focus is to the needs of the individual physician and patient in the US North American setting. UICC is a global organization and tries to meet the needs of a global community. I have no doubt that as the AJCC states, the evidence-based anatomic staging continues to be a critical factor to understanding cancer and treating patients. New breakthroughs in oncology are opening up ever more promising possibilities for precisely defining a prognosis and designing a treatment based on the patient's individual data. But there's this conflict, as I said, between the needs of the individual physician and patient and the needs of the surveillance community, which are different. But as I said earlier, I think, is that globally, there is a need to collect stage data. Stage data is very useful in treatment planning, but also in developing cancer programs and assessing the needs of a cancer community. Obviously, if you have early stage disease, the needs are very different from those with stage disease. So developing a cancer registry without being able to collect stage data is somewhat limiting. And this is just from World Health Organization instructions on developing cancer control, saying that cancer registry needs stage data as well. But you need to collect stage data. It must be available. That's always the case. In a benchmarking study, which took data from the UK, Sweden, Norway, Denmark, parts of Canada, and parts of Australia, chosen because they had similar sort of healthcare philosophies. This was developed in the UK because I was concerned about the poor outcome of patients in the UK. And this confirmed that the 5-year survival in the UK was less than in these other areas. One of the theories for that was that perhaps that's because patients are presenting with more advanced disease in the UK because UK patients don't want to bother their doctors. So stage data, but it turned out that only half the cancer registers they were dealing with collected stage data, and in fact, for the time period it looked at, other data had to be dropped because there was no stage data. Manitoba was part of this and obviously had stage data. But it also turned out that the stage data was not always the same. Some registries collected 5th edition, some collected 6th edition, and some collected 7th edition. Some used Duke, some used FIGO for gynecological malignancies, some used TNM. In Norway, they had their own localized regional and distant system, which was different from that in New South Wales, which used a localized regional and distant system as well. So they remained, and as I said, in the UK, colorectal surgeons, colorectal pathologists have been using the 5th because they didn't like the definition for isolate of a tumor nodule. And in Japan, some site organizations, such as the gastric cancer, use TNM, others use their own system. And when you compare and combine the two, it gets very complicated. But it is possible. But much easier if we all use the same system. This data from the benchmarking project showing the outcome in breast cancer by stage and by country. So every stage 1 cancer does very well, but if you look at stage 4, most are clustered around here, but in the UK it was significantly lower. And true in other tumor sites as well. TNM, however, has been questioned. I mean, particularly in North America, here often in breast cancer, anatomical extent of disease is irrelevant. What's more important is the PR and HER2 new status, and also gene expression profiling as well. But early stage breast cancer that's triple negative has a different prognosis than a triple negative patient who presents with metastases. So anatomical extent disease is still important. It may not quite have the importance that it had before. This stage grouping for breast cancer, which is unchanged between the 7th and 8th edition. Because of the desire to have an individual prognostic system for the patients and to incorporate gene expression profiling as well as HER2, ER, and PR status, the AACC along with the breast staging table, will produce another table with all these factors included. This is just a screenshot of the middle pages because it does amount to 152, I think, different stage groups. Not really intended to be this. It's really intended to be the first step to develop individual apps or prognostic tools that can be used for the individual patient-physician interaction. Altogether true that all patients with breast cancer in the US have early stage disease. This year data show that only 61% had tumors localized to the breast, 32% had regional, so node involvement, and 6% presented with metastatic disease. Other prognostic factors are very important, but anatomic cell disease is still important. And we should still continue to collect anatomical extent of disease and classify it. It's difficult to give a talk without mentioning alternative facts. This is a paper actually published last year. Actually, that means January, doesn't it? So this paper and subsequent editorial said, should we abandon TNM staging in favor of gene profiles in node-positive melanoma? Well, it really makes sense. I mean, this is only appropriate in node-positive melanoma, so you can't abandon TNM if you're talking about specific stage grouping with node-positive melanoma. And a lot of prognostic factors are particularly relevant for different stage grouping, not necessarily relevant for the whole tumor. So colorectal extended disease still remains. What we know is how to combine prognostic factors with those. Should we be combining them? Tumor profile is not the only important prognostic factor. Age is important, performance status, and other things as well, and is an individual prognostic tool of going more value where you can include all these things. This is an example that's available online from the Mayo Clinic. Again, it relies on TNM because this is for stage 3 colon cancer, but you enter the gender, you enter the performance status, the differentiation, the number of nodes examined, the number of nodes are positive, where it's in the colon, and the degree of invasion. There's a T3 tumor, then and treatment, and then you can calculate what the prognosis should be. So it's very useful for the individual patient, but not necessarily useful in the cancer surveillance community. So it's still important for prognosis, for treatment decisions and surveillance. In parts of the globe, it may be all that we have. So ICC at the moment is just classifying prognostic factors by whether they're essential for treatment decision making and part of a treatment guideline, and whether tumor-related, host-related, or environment-related, as can be seen in this grid. Whether additional, so they may be of additional value, but not essential for treatment decision making, and whether new or promising, and again, whether tumor, host, or environment related. And these have been published in the Manual of Clinical Oncology 2 years ago, and again, republished in the UICC TNM classification. So there's still a lot of work to do in identifying other prognostic factors, how to incorporate them with stage, but stage and anatomical extent of disease still remains relevant. I think, though, we realize, changes can be rapid, surveillance community want things not to change, but obviously they change all the time. They change not just because we have more information, but they change because we have better treatment and better imaging, and nasopharynx being a great example of that, where it's not anatomy has changed or the behavior of nasopharyngeal cancers has changed, but we can change the T category because the treatment and the imaging has improved. And so there's a need that's recognized that updating TNM every 7 years is probably not appropriate. It may be 10 years for some tumors, but it may be 2 to 3 years in other tumors. So there's plans to have a sort of rolling update with time. Breast may be a first example where the AJCC will be developing a prognostic tool, and if you do that, then you can add other prognostic factors as they become available. That's all I have to say. And obviously, any questions?
Okay, thank you, Dr. Brierley. So now we're going to go into the Q&A session of this session. So as Dr. Strictly mentioned in the beginning, if you have any questions, if you could use your chat tool to ask your questions, I will read them out loud to Dr. Brierley, and then he will answer them.
I'll try to answer them.
Try to answer them, okay. Great. So if anybody has any questions, you can go ahead and ask them now. One question, and the question is, we request IHC for P16IN oropharyngeal cancers. Should we request for EDAS as well?
I'm a GI and thyroid clinician, so I'm afraid I can't really answer that question. But I mean, I think EBV is important if you have the unknown primary and looking nodes. It's really for nasopharyngeal cancers, so unknown primary. I may not be able to answer the question.
Okay. Is there additional questions? We'll give it another 2 minutes or so for questions. Does anybody have any questions?
Is John a question if he's still online?
Oh, I think there's another question that just came in. This is from Lauren Hardy. So does new edition state whether testing for P16 in oropharynx should also be done in resection specimens versus biopsy specimens?
And again, not really it didn't specify that at all, no. I think the assumption is just it's biopsy. Most of the P16 positive oropharynx are treated with chemoradiation and don't have resections. So biopsy specimens certainly, I think, but again, it's not really an area of expertise. So that the UICC tries very much to stay clear of giving advice on investigations and pathology techniques and analysis. It tries to be relevant. Not everything is available everywhere.
Next question is from Dae Tong Kim. He asks, could you explain collaborative staging a little more?
Briefly, but I don't think it's really relevant as it's sort of died. It's not being funded anymore. Collaborative stage was not really a staging system. It was just a way that it actually changed its name to Collaborative Data Collection System or something. It was just a way that enabled cancer registrars to collect raw data. In the past, when they collected stage data, they collected whether it was a T1 or T2. This enabled them to collect whether it was a 1.2 centimeter or a 2.5 centimeter tumor. But a big advantage of working with synoptic pathology reporting, so you could import the synoptic pathology and collect that raw data. Now it's just dependent on T and N, and again that is available on the synoptic pathology. It was useful. It meant that you had the data going back to 1950. So if T category changed, like it did in thyroid, so previously T1 was less than 1 centimeter, the last two editions is less than 2 centimeters. If you just had T1 data in the database, it meant that you didn't know whether it was less than 1 centimeter or less than 2 centimeters. It was useful to have the raw data to do that backward compatibility. That's no longer available because of the complexity. So at the moment, we're still collecting collaborative stage, but we'll only do so probably until the end of next year, when 8th edition will be introduced into cancer registries.
Next question is MMR essential for colorectal cancer?
No, I mean, I think in our institution we only use it in analyze it in certain cases. So it has been collected as a site-specific factor in collaborative stage, but most of our patients don't have it assessed.
So there's no more questions at the moment.
It's certainly not part of staging. Go ahead.
Oh, sorry. Are you still asking the question?
No, I was just saying on that going back to that question, it's not a requirement for stage.
Okay. The question is from Lauren Harvey. Our oncologists have asked for MMR status in the context of stage 2 tumors. Sorry.
Well, that's really to help with decision making with treatment, not part of cancer staging. So it's not a requirement for cancer stage. It would be what they want to help guide the treatment of the patient. So a clinical decision made by the oncologist that they require it in those group of patients.
Is there any more questions?
John, can you hear me?
Yeah.
You had a question for me?
Really, just because I thought the interest of this group as well is plans with regard to the CAP checklists and updating them and when they're going to be available for release. Is the plan to make them available for updating, but then be in place for 2018, or is it still uncertain?
No, very certain. It's I just came from actually a weekend meeting of the Cancer Committee. There's going to be 2 releases this year. There's going to be a release within the next 3 or 4 weeks that relates purely to the GU protocols. So I think there's 7 protocols that have been updated with respect to WHO 2016 and other prognostic factors. Those ones are still going to have the AJCC 7th edition in them. However, all the protocols, including the GU ones, are in various stages of completion. I think they're mostly completed from what I gather, and they're with the PERT group, which is the Electronic Reporting Task Force, being converted into electronic checklists as we speak, and they're going to be released as a block in Q2 of this year. So sometime probably in June, I would think. And that's so people can actually start to socialize those checklists, and also they'll be released as XML downloads to the software providers to be implemented within the various software solutions as well. So there's 2 releases this year. One's purely GU with the 7th edition, and then the big release will be in Q2 of, I think it's 56 protocols or 60. I can't remember the exact number, 50 to 60 protocols, all updated with the 8th edition content.
Thanks.
Anybody else have any additional questions? Wait a couple more minutes. Okay, so if you don't have any additional questions, I think that you can end this session. Doc, would you like to
Sure.
over?
On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I really want to thank Jim Brierley for a great presentation today and in updating us on the changes I think that are associated with the TNM 8 release. A reminder, the live and recorded versions are eligible for CME credits. In order to obtain your certificate for participation, please provide your name and email address at the link included in the session notice. Here you also find the optional session evaluation form, which you're encouraged to complete. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions. See the session notice for this important information. The upcoming sessions are as follows on February the 22nd. So next week at this time, Dr. Tony Ng from Vancouver Coastal is going to talk to us about thyroid cancer. Then we're going to have a pediatric path one on the 22nd of March. Dr. Dina L. Delmalati is going to talk about Ewing's PNET. Then I'll give an update on the new prostate checklist on March the 29th. Thank you very much for your participation today.